At what point should someone try PRP in terms of the number of oocytes retrieved prior and or age?
If you've gone through a cycle of IVF and it hasn't worked for you, it's a good time to talk about PRP. So I do that with everyone, no matter what your age is. As far as the number of blastocysts, I don't take it into consideration. Typically, I offer it to patients who have gone through cycles that haven't worked and patients with DOR or primary ovarian insufficiency.
Good evening and good afternoon to everybody. My name is Pete Freeman. I'm the clinical specialist and principal of Paragon Biologics, and it's my honor to be hosting tonight's webinar. I had the great fortune of meeting Dr. Peter Everts, the Chief Scientific Officer of Insight, a little over 3 years ago, and we began the discussion of how to present a scientific rationale for utilizing platelet-rich plasma in the field of women's health, primarily reproductive endocrinology. And as fate would have it, shortly thereafter, we met Dr. Amy, who has been a great partner in all of this. So I am thrilled tonight to be joined by Dr. Amy, the Egg Whisperer. Dr. Amy will be presenting on PRP and Ovarian Rejuvenation. Let me introduce Dr. Amy, lovingly referred to as the Egg Whisperer by patient that's caught on. She's a fertility specialist with a practice in the San Francisco Bay Area and has been practicing there for over 15 years now. She consistently tops patient review sites, Fertility IQ, Yahoo, Yelp, Google. Today, her global platform is known for sharing a message of fertility, hope, and positivity. And we are very, very honored to have her here with us tonight. Thank you so much, Dr. Amy.
Thank you, Pete. I'm actually sitting at the same desk that my dad worked at for over 40 years. And in fact, today I saw a patient. I've helped her have 2 babies, and guess who delivered her? My dad.
That's amazing.
I know. I feel so blessed and lucky to love what I do and just to get to be a part of this community in such a special way. So we're going to talk about exploring ovarian platelet-rich plasma. This is the thing. Every woman runs out of eggs, but so many women that I see in my practice, they run out before their desire to have a baby runs out. Wouldn't it be easy? You run out of eggs at the same time that you don't want babies anymore? But the reality is, as a society, everything is happening later for us. Our milestones are moving. And our milestone for when we want to have our first baby is so often now at a time where our eggs are acting older because they are, and that is normal. And just because getting pregnant is harder doesn't mean that there's something wrong with you. So I wish there was something out there that would guarantee that my patients would not have to use an egg donor. Doesn't mean that egg donation is wrong. It is not. It's an amazing option to grow your family. But I'm always looking for something that I can offer my patients before egg donation. And in so many cases, I can say that if this patient or that patient hadn't done ovarian PRP, she would likely have needed an egg donor. And that's okay. But I strongly feel that every woman who is considering egg donation should be offered ovarian PRP. And we'll talk a little bit more about it now. PRP, or platelet-rich plasma, is a part of your own plasma that's obtained by separating the components of a blood sample in a process called centrifugation. In simple terms, it's a high concentration of platelets derived from your blood. It's been in use and under study since the 1970s, primarily for regenerative purposes in fields like dermatology, orthopedics, and aesthetic surgery. It involves infusing PRP directly into the ovaries, much like an egg retrieval procedure. I talk about it as a facial for your ovaries, except you're taking your pants off. You see, I bet you didn't think that you were coming here for a comedy show. So the PRP contains growth factors that supercharge the healing and regeneration process in the area where they can be injected or infused. And these growth factors can stimulate stem cells to grow and become the necessary cells in damaged or dormant areas. They can also promote the development of new blood vessels, which bring oxygen and nutrients to the targeted area. So here's a step-by-step approach. So it involves drawing an amount of blood from your own veins. Then we spin it in a special centrifuge. It looks like a spaceship. It's really cool. And this then allows us to extract the rich platelets. Then they're used for the ovarian procedure. During the procedure itself, I inject PRP transvaginally under ultrasound guidance into at least one ovary Ideally, both if possible. Most of the time, it can be done to both using a tiny needle. I use a spinal needle, which is even smaller than the egg retrieval needle, all while you are asleep. So I use a combination of fentanyl and propofol for the procedure so that you go to sleep, you have a great nap, you wake up, and your ovaries are rejuvenated. The ovaries are like special egg factories. They are two small almond sized organs located in the lower abdomen. Main job, produce eggs. Needed for, I know you all know this, making babies. They also produce hormones like estrogen and progesterone, and these hormones are really important for many things like regulating periods and helping the baby develop. When a girl grows up, her ovaries start releasing eggs every month. And if one egg meets a sperm, this can lead to pregnancy. And when that egg gets fertilized, the ovaries keep producing hormones to support the growing pregnancy. So, this is the thing. Sometimes the ovaries aren't working as well as they should. And this is the definition of diminished ovarian reserve. It happens to all of us. And this happens when the number or quality of a woman's eggs decrease before she's even reached menopause. I think menopause should be rebranded as me no eggs. Because when you say the word pause, it makes us feel like it's just on pause and your eggs are going to wake up again. And this is why I see so many patients that say, well, I'm 50, I'm ready for a baby, I feel fertile, and you're in menopause, but they don't realize it means permanently no eggs. It can make it harder for her to get pregnant. And when you've gone through complete menopause, let's say before the age of 40, that's when you're diagnosed with something called primary ovarian insufficiency. This can cause irregular or absent periods, obviously trouble getting pregnant, and symptoms like hot flashes. Ovarian PRP has actually been found to improve ovarian function, and I've seen it help patients who have the diagnosis of decreased ovarian reserve and primary ovarian insufficiency. Mind blown. I know. You're like, what? FSH over 90? No periods for over a year? And you do ovarian PRP and you can actually get pregnant? I have seen it with my own eyes. I could say right now, it's not countless stories, but I can probably say on two hands now, I have seen it happen. I have one patient who promises that she's going to share her story. She wants to share her story once her baby's here and let everyone know what she went through. So, PRP can activate dormant follicles, potentially increasing the number of follicles and improving the chances of obtaining a healthy egg or eggs for a successful live birth. There's also inconclusive research suggesting that it may stimulate ovarian stem cells to develop into follicles, which can then mature into eggs. Some studies indicate, and I have seen this myself in the data that we collect, that PRP can lead to improvements in FSH, estradiol, and AMH as early as 2 weeks after the procedure, which has effects that can last up to 3 months. I've actually had patients where I've seen the effects last for up to 6 months. So I monitor my patients every 2 weeks or so after their ovarian PRP procedure. I look at the follicles, I check the levels, and we talk through when is the best time to start treatment. And I'll tell you this, my first live birth after ovarian PRP was in a 41-year-old woman who did 3 cycles before meeting me. No blastocysts, no normals. First cycle after ovarian PRP, pregnant, here we go, naturally. What? I know. So I encourage patients to try naturally. And a lot of my patients are scared. They think it's dangerous, but it is not. These hormone levels are crucial for fertility as they are indicators of available follicles or eggs and play a vital role in achieving a desired pregnancy and healthy childbirth. So the thing is that even if your levels, as we're watching them every 2 weeks, do not change, sometimes they go down, that might not matter as much. I have had cases where a patient's follicle count, AMH level even dropped, but the first time they ever got a euploid embryo was when we started. I have a patient, I'll never forget her. She's 40 years old. She had 3 follicles. Previously, she had a slightly higher egg count. AMH was higher. After ovarian PRP, her levels went down. She said, Amy, no, I think we should still start medications. And we did. And guess what? I mean, you'd have to see it to believe it. And Peter, we should have another webinar where I actually share these case studies of each patient and maybe have them send a little video because their stories are wild, wildly favorable and positive. So back to that story, 2 mature eggs, 2 blastocysts, both euploid. And these patients of mine who are doing ovarian PRP, they're often doing it after many cycles that were not successful. Ovarian PRP can also provide some relief for menopausal symptoms as it can decrease the severity of their symptoms. I have a patient that swears by it. I think maybe she likes the anesthesia a little too much, but she's done it so many times. And she's like, Amy, it just keeps my ovaries functioning. I'm having more regular periods. I'm not having hot flashes. So there are patients that can benefit from that. Hopefully, we're going to have better drugs out there so that patients aren't relying on ovarian PRP for their menopausal symptoms, because that's a lot to go through. But the fact that they feel better, what that tells me is that it is doing something at the level of the ovaries. So women with diminished ovarian reserve, DOR, or POI can potentially benefit. I've had patients who don't respond. It takes a long time for their follicles to grow when they are in a traditional IVF cycle, benefit. I've had patients who have benefited if they've had, let's say, no mature eggs or no blasts, and then they do ovarian PRP and they go on to have mature eggs and blastocysts as well. Also, like I said, women experiencing menopause may also benefit. So here's the thing. Since PRP is derived from a patient's own blood, the risk of rejection or adverse reaction is minimal to none. I have performed now over 300 ovarian PRP procedures myself. I have worked with another physician, meaning referred patients to him for over probably 6 years now. So in total, it's probably over 1,000 patients of mine who've done ovarian PRP without a single complication. It's entirely natural, very safe, and FDA cleared. However, there are rare complications associated with the procedure. Anytime you're doing anesthesia or placing an IV or inserting a needle through the wall of the vagina, you might experience potentially pain, bleeding, cramping, infection, damage to adjacent organs. The way I do the procedure is very carefully and gently, using the smallest needle available, called a spinal needle, introducing it to the ovary in the safest way possible, always doing no harm. It should only be done by qualified healthcare professionals after thorough review of your past medical history and potential risks. Your chiropractor, while they might be good at some things, we don't want them inserting a needle into your vagina. I joke, but not really. There are folks out there who might be offering this treatment who probably should not be because they don't have the skill set to be doing it. So just kind of sharing a picture of someone getting her blood drawn here. She's comfy and cozy. The nurse is putting the little tourniquet on her arm and she's getting ready for her blood draw. So you can see after the blood draw, she gets her IV placed. And that's the setup on the left. You can see the speculum with the light inserted, the PRP ready to go with the cap on it. You can see the needle there with the silver end on the left side. And then that's basically the setup before the actual procedure. So, recap of key points of ovarian PRP. Ovarian PRP is a cutting edge treatment that involves using a woman's own blood plasma rich in growth factors to rejuvenate ovarian function. It's done under sedation or anesthesia. It may improve ovarian function and fertility. I tell my patients I see an improvement in approximately 50% of the patients who do it. What does that mean? Does it mean 50% will get pregnant? The answer is no. What I mean is I can see a drop in the FSH, a rise in the AMH, an increase in the follicle count, an increase in the blast formation rate in at least 50%. It can help women with DOR, which is diminished or decreased ovarian reserve, or premature or primary ovarian insufficiency, as well as in patients who have, I hate the word IVF failure because no one's a failure in my mind, but IVF issues, meaning you've done IVF cycles, they haven't quite worked, and you might need a little help. And maybe someone has brought up egg donation. So you might want to consider doing ovarian PRP first. I also offer ovarian PRP to all my patients over 40 as a first step before they do their first IVF cycle. My approach to care is to always talk to patients about what would we do if this first cycle that we did didn't work. So they have the opportunity to be a part of the decision making and make a choice as to whether they would like to do it before their cycle. One day we'll be doing this, doing in patients who will be doing multiple cycles, also doing an ovarian PRP infusion at the time of the egg retrieval for future cycles. So in patients who want to bank embryos, this is another way of doing it. It is natural, safe, and effective. Ovarian PRP is a procedure I provide often. And if you or someone you know is struggling with fertility issues, this could be a viable treatment option. And I encourage you to talk to a healthcare provider that specializes in this. Thank you, Pete and Dr. Everts, for inviting me to join this webinar with you guys. I love what I do. I love helping people become parents. And I'm so appreciative of your company for giving me this tool, because I know that when I'm delivering PRP into a patient's ovary, I'm using the best possible product out there. I'm hoping that through my patient stories, people who are coming to me, they're just screaming it out on a megaphone saying, consider ovarian PRP, and hopefully other doctors out there will reach out to me, and then they'll bring their team in to help set them up. Because just like Dr. Everett said, not all PRP is the same. Okay. So when you read studies out there that says ovarian PRP doesn't work, I promise you, they're not using the system that we use here. Right, Dr. Everett, do you agree?
Yeah, I absolutely agree. We should approach it like medicine, right? If you prescribe a patient antibiotics, you let them know you need to take it for so many days in that dose, right? And that's where we need to be here as well. It's a compound medicine, actually. There's way more cells in it than platelets by itself. And if we do not have that biological mindset as well, how can we influence or help nature getting things done? Then, well, things are not going to work out. And those of you who have an interest, read more than just the abstract, read more than just the title. Go into the methodology of studies and see what is it they have been using, and send an email to the research team.
Thank you, Dr. Amy, so much. That was fantastic. I love hearing the success stories.
Yeah, me too.
It's just, I appreciate you bringing these stories to us. I think that's so influential, and we need to hear that, because that's the bottom line. Are we helping patients? This has been a very high impact webinar with a lot of science, a lot of stories that can impact a lot of people. And I know based on the presentations, we've gotten a lot of questions. We'll just start with the first one. Can a 50-year-old woman do PRP as long as she is not in menopause or even in menopause? Also try to conceive naturally after PRP and not do IVF.
If you're going to do that, expect it not to work. I was born with a smile on my face. It's very irritating. I'm the most positive person in the world. If you're 50 and you want to have a baby and you still want to use your own eggs, I'm going to help you. Guess who has frozen the oldest egg in the United States? Me. I have frozen the egg of someone who is 51 years old. So I will give everyone a chance. And if you want to try and you want to do ovarian PRP and see if you can get pregnant naturally, do it. This is a journey. I mean, if a man had the chance to get one sperm, would all be like doing CPR on his testicle. So my recommendation is like, go in it, go through it, eyes wide open, and say, this is part of my journey and an experience I want. It's not going to work. I'm just wasting my money, but I just want to see from my own eyes. I know these doctors, they think they know everything about me, but the likelihood of it working is zero. But if you want to have the experience of just seeing for yourself, I don't see that there's any harm in that. What do you think, guys?
There are no promises, there are no guarantees. You only need to know is make sure you go to people who have an experience and tell you their real true story instead of getting them into your clinic and well, see what's going to happen, right? So I agree with Dr. Amy completely.
Next question, is PRP preferred over IVF? Are there any negative side effects, and who would be a prime candidate for PRP?
PRP isn't preferred over IVF. Think of PRP as like I said earlier, like getting a facial. Think of it as like a supplement you would take to prepare for IVF. So I think of it as like part of your IVF preparation. The negative side effects or the disappointment that could come if you did it and it did not work. So you have to realize that there are no promises and no guarantees. When I have a patient do PRP, she actually signs a form that says, there are no promises, there are no guarantees. I understand that this may not work. And then the prime candidates, I think, are women who've gone through IVF, they're making embryos and they might just not be as good quality or genetically normal. I think those women have the highest chance of success. But I also have seen great success in women who have a very low egg count, perimenopausal, or even patients who've already been diagnosed with menopause or primary ovarian insufficiency.
At what point should someone try PRP in terms of the number of oocytes retrieved prior and or age? Is the number of blasts taken into consideration also, or just oocytes retrieved?
If you've gone through a cycle of IVF and it hasn't worked for you, it's a good time to talk about PRP. So I do that with everyone, no matter what your age is. As far as the number of blastocysts, I don't take it into consideration. If it's, I have patients who, let's say I've retrieved actually 12 eggs, they're 33 years old, and I get one blastocyst that's normal. I've actually offered her ovarian PRP. The next cycle, I get 5 normal. I don't know. Is it just cycle to cycle variation? Did the ovarian PRP help? I offered it to her because I said to her, maybe this will help. And she said, yeah, I want to do it. I want to try it. So, everything for me is individualized, and I just offer patients options to see if they want to do it before another cycle. But typically, I offer it to patients who have gone through cycles that haven't worked, and patients with DOR or primary ovarian insufficiency.
Is there any early data on the likelihood of embryo formation with PRP? Also, is there any evidence adipose PRP is more efficacious?
Yeah. So as far as early data on likelihood of embryo formation, I think if you've done a previous cycle, it might increase the number of blasts. I tell patients by at least one. Dr. Murphy has published a study. You can look it up on PubMed about the increase in blast formation after ovarian PRP. We don't know about whether adipose is more efficacious. However, it might be. It involves doing a procedure that's similar to a liposuction, where a needle is inserted right below the skin and fat is aspirated, and then that fat is spun, and the stem cells from the fat that is spun are then introduced into the ovary. I have had patients who've done adipocyte stem cell rejuvenation. I don't have enough experience yet to say if it's better or not, but in patients who have not been successful with ovarian, I often refer them to Dr. Murphy for adipocyte stem cell rejuvenation. Dr. Everts, do you have any input on whether you think one is better than the other?
If you look at the systematic reviews that have been published and the number of patients that have been treated in total with PRP, then that number is significantly higher than with adipose. There is also more variance in adipose preparation. So what is it that you find in injecting? There are different forms of adipose preparations, like tissue stromal erection and cellular stromal erection, and the last one is even not allowed in the US. We cannot use enzymes to prepare a biological product to create another product. So the rules and regulations for anything has to do with mesenchymal stem cells from adipose or bone marrow tissue, they are completely different than from PRP. So depending on what kind of adipose preparation is being used, you might be in violation with the FDA.
Yeah, and we don't want that.
Well, the good thing, what really needs to be done, and I see that in many other areas of medicine as well, there's no straight head-on comparison between PRP versus adipose tissue preparation. It's one or the other, and a very scarce amount of studies in other fields of medicine have been used cannot make a clinical significant difference between one over the other. So yeah, it's maybe like the stock exchange, right? Something's new, let's try it, and all of a sudden it is going well somewhere else. But I think it needs to find its place also in infertility more than what's right now.
How long after a myomectomy can PRP be done?
As long as you can get up and walk into the building, we're good. So myomectomy doesn't influence the timing of ovarian PRP at all.
Should the IVF medication in conjunction with PRP be less intense? For example, a gentle IVF.
For me, when I look at someone's follicle count after ovarian PRP, I don't say, oh, I need to give you low dose stim because that's going to be better for you. I say, oh, I'm going to use the amount of medication that I think would be appropriate based on the number of follicles you have to help grow the cohort of follicles so that I can get as many mature eggs as I can safely.
How long after a PRP procedure will you see results? Meaning, how long after the procedure can you do an egg retrieval cycle or even try natural?
So I've had at least 2 patients get pregnant, even in the ovarian PRP cycle. So I tell patients to seduce their partners as soon as I see green light. So what I do is I take a look at the screen and I see how many follicles the patients have. I document when I think they're going to ovulate. And sometimes you ovulate after ovarian PRP. So I ask patients to consider trying to conceive in the same cycle that I've done ovarian PRP in. And I've had patients get pregnant with healthy babies. I tell patients to do their first IVF cycle approximately, or at least start stem 2 weeks after ovarian PRP. So what do? They come in and see me. We do a hormone check. We check AMH. I do an ultrasound. And based on where they're at, we then decide when we're going to start IVF.
There is a question in the webinar chat, I think addressed to you, Dr. Amy. Please clarify the success before beginning M-site prep method. Do you monitor growth factors of the PRP? How many injections per ovary? What volume of fluid is injected? Do you do PGTA on all PRP injection patients?
There are no two ovaries that are alike. Every ovary is a different size. And so what I do is I infuse an amount that I think is appropriate to get around as much of the entire perimeter of the ovary that I can.
Gotcha.
Some ovaries are going to be bigger than others. Some will take more volume than others just because of the size. As far as PGT, for patients who are doing IVF, most patients of mine are doing PGT or embryo genetic screening. And so the before question, I'm not sure I understood that part, but I hope that that answers most of the question.
Are there particular days in a cycle for which it's best to perform PRP?
No, it's not cycle day dependent. I'm very careful if the patient's ovulating, for example, on the day of the PRP, not to enter the corpus luteum or the follicle, that the mature follicle or the dominant follicle. So for me, I can do it any day. If someone's on their period, it also doesn't matter if they're bleeding. I do document and like to know where a patient is in her cycle. I've had patients who are even taking fertility pills to try and get pregnant in that cycle. And I'm just mindful of, what I'm seeing. I also have patients who have an ovarian cyst at the time of the ovarian PRP, and let's say they have a 4 centimeter simple cyst, this is a good time to actually drain the cyst because you're already there. So for patients who have cysts, you're perimenopausal, that's very, very common. You're doing ovarian PRP, so you can infuse a PRP and at the very end of the procedure, have that cyst drained. So you can move forward with IVF right away without needing another procedure, or move forward with trying to conceive naturally.
Is there any way to determine how many PRP rounds may be needed? Did you need a second or maybe even a third?
Yeah, for me, that's individualized. It's based on the patient, the clinical outcomes that I'm seeing. And so I have patients who do a cycle and then we have a good outcome and then she's not ready to move forward again. And then we wait a few months, then she does another PRP session, then we do another IVF cycle. So it just kind of depends on the patient. And I have some patients that just want to do 2 separated by 30 days and then do her egg retrieval after 2 ovarian PRP sessions. So it just depends on the patient. And I talk to patients about that. How many does it look like we want to do? What would happen if this first cycle didn't work? Should we go back and do another ovarian PRP or not? So those are questions it's not like a one size fits all answer, just based on your hormone response and the clinical outcomes that we're seeing from the IVF cycles that we're doing.
Are there any comorbidities you would not consider while utilizing this modality for?
Women who are doing this, who are in menopause, their ovaries are very, very small. Your ovarian PRP should not be the first time that the doctor has done an ultrasound on you. You need to make sure that your ovaries are visible on ultrasound and easy to access because, it's possible that they might not even be able to do the ovarian PRP and they won't find out until after you're asleep and under anesthesia and after they've drawn your blood. So I always request a pre-ovarian PRP ultrasound in patients who especially haven't had an ultrasound in the last year who are doing it with me. So that's an important thing to remember. So if you're 50, for example, and you want to try it, make sure your doctor can actually see your ovaries and you have ovaries that are large enough to infuse with PRP.
We discussed timing a little bit for the treatment. The range I've heard is from 2 weeks up to 3 months. What would make more sense from a molecular standpoint?
Yeah. So what I would say is some patients respond as soon as like 2 weeks. Some patients, it can take 4 weeks. And I've seen some patients where it isn't until about 60 days. And so that's why in my patients, I have to tell them, look, we're just going to wait, be patient and see, like follow your follicle count, follow your AMH. And then boom, all of a sudden you have a great set of follicles that you want to start, talking to. And so for me, I really like when I get to IVF and a patient has the chance for me to retrieve 3 mature eggs. 3 feels like I could get at least 1 mature egg. So, I mean, I deal with a lot of patients who have like 0 to 1 follicles, and I'm trying to do everything I can to increase that number. So 2 weeks to 3 months. And in some cases, I've had patients see, longer lasting effects where all of a sudden their follicle counts are high and they're maintaining them really high over a long period of time. And what I would love to do is, I don't know if it's something about their genetics. I'm not sure why, I can have, let's say, a 43-year-old whose AMH stays up for, a year. I don't know why. Just I have no idea.
thank you so much. This has been fascinating. I know that all the attendees appreciate it. I certainly appreciate your time. Dr. Amy, thank you for joining us all the way from California. And Dr. Everts in Fort Myers, this has been fantastic. We greatly appreciate your time, your expertise, your knowledge. And we look forward to doing it again. Dr. Amy, I think that was a great suggestion. There's so much more to learn in this subject, and we greatly appreciate you both.
Thank you for
Thank you, Pete, for organizing it.
Thank you, everybody. Have a great evening.